this computer. Okay, do you have any question from last week? Questions from last week? Fluids, electrolytes. We're starting the APG, the arterial blood gases or ABGs, analyzing, doing the interpretation for the ABGs. So no questions. Did we go over these questions last time?
Not yet.
No, we did not.
No, we did not.
Okay, so who want to volunteer answering the first question?
Serum sodium, I think.
So can we read the question first and then answer it?
Yes, it says,
What about that?
what is the best way to determine the water balance in the body? Serum sodium?
Okay, any other answers? And we need, like, when we answer the questions, better that we will give rationales so we can understand the the concept behind each question.
I would think intake and output.
Intake and output, yes, I think.
So okay, this is the time we're trying to to exercise what is called the critical thinking and the clinical judgment and all these concepts, and as we answer the nursing like English kind of type questions like this. So we are looking at what is called the excellent indicators of the fluid electrolyte. If the patient has hypovolemic or hypervolemic, like fluid volume excess or fluid volume deficit, what determines the fluid enough or insufficient in the body? We have different determinants and indicators. It can be the body weight. It can be the intake and output. There are also lab values that we can review as osmolarity, and see the concentration of the blood. And so there are urine output and all of this. So we have too many indicators, but the excellent indicator among all of these would be, what would be like in the top of them would be the most determinant of the fluid electrolyte imbalances is
the daily weight.
Daily weight. So body daily change. So the change in the daily weight, especially a sudden change, an increase or decrease, that's an excellent indicator of the fluid volume loss or gain. Number two, volunteers, I would like people to participate so they can read out loud the question, and we go over the answers and figure out, not, I mean, I'm not asking because, if you do not know the answer, that's fine. It's just when you participate, you can, aloud say the question, and then you will, go over the question, the answers, and see if you have the answer, that's fine. If, others can answer it. Go ahead.
Which patient is at greatest risk for fluid and electrolyte alterations in hemostasis? I said A, infant with diarrhea times 5.
Excellent. Why?
Because when you have diarrhea, you have high risk to become dehydrated.
Good. Because we know that the infant, they are at high risk because the water content, remember we said the water content in infants is about 70 to 80%. So they have lots of water, but still they will be at risk. If they lose water, then will be more at risk of dehydration. So the elderly, they have 45 to 55, don't be at high risk as infants who is having diarrhea 5 times, right? So that's a rationale why would, if I ask for a rationale for, for request for the answer, that would be the answer is that the infants that are at high risk because of the infants' water content at 70 to 80% of their body weight. So more likely to experience the alterations or the electrolyte imbalances and the fluid electrolyte imbalance, especially like dehydration, if they lose fluid, especially from vomiting, from diarrhea 5 times. Okay, next question. Volunteers?
I'll read.
During the post-operative care of a 76-year-old patient, you monitor her intake and output carefully. What is she at risk for? Fluid and electrolyte imbalances. Oh, why? I'm sorry. Why is she at risk for?
Can we say C? Older adults are more likely than younger adults to lose electrocellular fluid during surgical procedure. No.
During surgical, no.
Yeah.
I would say D. Losses of fluid are more significant because fluids account for 50% of their body weight.
Okay, so right, D.
Dehydrated.
Right, D, the last one, D as in dog, right? So the small losses of fluid are more significant because the body fluids account for about 50% of body weight in older adults. Number 4.
The patient's laboratory results indicate a sodium level of 133 ME. I don't know if that's a Q.
That's fine, 133 mil equivalent.
Okay. And potassium level of 3.3. The nurse practitioner orders only potassium replacement. What is the best explanation?
I would say B.
When both potassium and sodium both are important electrolytes. None of them more important than the other. And potassium will result in more serious complications, but both are most, they're important at the same level.
D.
I would say A.
A, yes. Yeah, we said B is not incorrect. B is incorrect because both of them are important, sodium and potassium electrolyte, but potassium may result in more serious adverse effects or complications than the sodium, especially on the cardiac dysrhythmias and cardiac arrhythmias. Here, the potassium is an intracellular electron. Remember, I said the potassium inside the cell, right? So the only way to measure the potassium is measure it in the plasma. That's when you draw blood specimens into the lab for electrolytes, looking for the electrolyte values, sodium, potassium, chloride, right? So we cannot measure the potassium inside the cell. We measure it inside the potassium inside the plasma. So in the plasma, which is extracellular potassium, but it's an indication of the the amount of potassium in the cell. So if the patient is hypokalemic, obviously we don't have enough potassium in the intracellular. If the patient is hyperkalemic, then we have lots of potassium in the blood and the cells as well. So that's would be the answer is A, is that extracellular potassium deficiency reflect a much greater intracellular deficiency. So it's like an indication if it's less in the plasma, less in the cells. More in the plasma, more in the cells. Number 5.
What will
Volunteers?
happen if a patient has a severe deficiency of albumin molecules in the vascular system?
So what's the effect of the albumin molecules as protein, albumin, colloidal pressure? Remember the colloid pressure, oncoid pressure? We said the hydrostatic pressure, osmotic will push fluids out of the compartment. Oncotic colloid pulls the fluid back into the compartment. So this is the vascular system. And you have albumin or protein molecules exerts the oncotic colloidal pressure. It should pull the fluids back to the vascular system. So the answer would be, I'm sorry. So there is deficiency here. So there is deficiency of the albumin, right? We don't have enough albumin, so we have decreased oncotic colloidal pressure in the vascular system because of the deficiency of the albumin molecules. We don't have enough oncotic pressure due to the deficiency of the albumin, so the fluid is not going to be retained in the vascular system, so it will exit the vascular to the interstitial space, right?
Yeah.
Because oncotic, supposed to these molecules, the albumin, to pull fluids into the vascular system. We don't have enough in the vascular system of the albumin molecules. So then the other scenario, which is that the fluid will leak, right? It will leave the vascular system to the interstitial space. You got the point?
Yeah.
So then what is the answer?
A.
Right. The oncotic pressure is affected, so the edema will result. So the fluid leaking from the vascular system to the interstitial space will result in edema. So whenever you had a question about the oncotic or colloidal pressure, remember that the colloidal pressure or oncotic pressure, it results from the presence of the molecules, protein, albumin molecules. Deficiency of that, then that drop, that pressure will drop. And always these molecules will pull the fluids into the compartment. If they are insufficient, there is no, the fluid will leave that compartment. So the oncotic pressure, which is the colloidal osmotic pressure in this case, is the pressure exerted by colloids in the solution. So the protein molecules will attract the water. It will pull the water in. So pulling the fluid into so in this case, the fluid is going to be pushed out of will be out of the vascular system into the interstitial space, and the edema will develop. And that would be like in patients with who will have ascites in response to the liver cirrhosis because of the portal hypertension. And we'll go, we'll discuss, this in details and in more details and specific, long discussion about this in the GI hepatic disorders or system. Number 6.
What is the proper explanation for the clinical manifestation of confusion in a patient with hypernatremia?
So confusion and patient with hypernatremia.
Is the answer for that D? Brain cells are shrinking?
Yeah, so exactly. So what happens to the brain cells is that this is confusion as one of the significant neurologic manifestations in patients with hypernatremia. And that's because of the shrinking of the brain cells as the increased extracellular fluid osmolarity. Remember that the blood, so we have blood and the brain cells, plasma and brain cells. The plasma hypernatremic, so high sodium content in the plasma. So it became hypertonic, right? So it's going to pull water from where? From the brain cells, right? The plasma is hypertonic because of the increased sodium content. So fluid is going to be pulled from the brain cells. So the brain cell shrinking results in the manifestations of confusion. Okay, number 7.
Which is an example of third spacing of fluid.
Remember we said first spacing, second and third spacing? First spacing, normal distribution of fluids. Second spacing is edema. Third spacing, when the fluid is trapped in the compartment that cannot be resolved or treated unless we intervene with like paracentesis or thoracentesis or so in this case, third spacing would be
D. D.
increased
This is C.
intracranial pressure.
D.
Let's
C.
just think about the increased intracranial pressure.
Itis.
That's fluid.
Yeah, for the increased intracranial. If we go to the to be as an answer, so increased intracranial pressure that can be treated with number 8. Question number 8 talks about a medication here, and one of the meds is called mannitol or osmotrol. You will learn about about this in pharmacology. Is that it's a hyperosmolar drug that is going to pull the fluids from the cells and because increased intracranial pressure means there is a brain swelling, brain edema. That's why there is an increased ICP, increased intracranial pressure. So this is a little advanced at this stage. I don't want to go into confuse you with the basic stuff because we'll cover this in in the neurologic system about the increased ICP and the signs, symptoms, and pathophysiology of increased intracranial pressure. But this patient had third spacing, and we said that we intervene by when the fluid is trapped in the abdomen or around the lungs or in the joints, like synovial fluid, accumulation of synovial fluid. That's an example of third spacing. You have to physically intervene by aspirating the fluid. Paracentesis or thoracentesis or spinal aspiration of the synovial fluid from the joint. So in this case, an example of third spacing would be
Ascites.
Ascites.
The edema.
Right. The ascites, not the edema. The pitting edema, it's a second spacing. The pitting edema is second spacing because you can treat it with, like first line of management would be give furosemide, Lasix. Diuretics would treat the pitting edema. But ascites, you cannot treat ascites with any drug. Partially, you can get small amount of, of the ascites out of the abdomen, but 99% of that fluid should be removed physically by paracentesis. So that's why we call it, the fluid is trapped in the cavity and it has to be removed by mechanical intervention, like paracentesis in this scenario, which is ascites. So ascites is a third spacing. Edema is a second spacing. Number 8.
Which patient is at the highest risk for hypernatremia? I would say D.
A.
A.
I think it's A.
Yeah, it's A.
I think it's D also.
As well.
Hypernatremia.
When you don't take enough water.
High sodium.
You don't have enough water.
So it will be the risk for hypernatremia is highest for someone who has limited access to fluids or ability to obtain the fluids. So a middle-aged, patient who's complaining of thirst, they would definitely reach out, to drink, or they will assist themselves or ask somebody to, to give them a drink, and that will resolve the problem. But an infant with diarrhea, that is, yeah. So the infant the infant has a high percentage of body weight as fluid, as water, and are susceptible to the fluid loss from diarrhea. So the hypernatremia, it's not a problem in the alert person, because the alert person, alert oriented, they're able to, when they have that thirst sensation, then they will be able to assist themselves to to get a drink or fluid. So they have access to water and they can sense the thirst, and then they will drink, and that will resolve the problem or prevent the problem. Athlete who can drink is not at risk. And fluids, and the who is vegetarian, or people who are who are vegetarian, the fluids and vegetable, the fruits and vegetables, they contain a large amount of fluids, and we can say that the highest percentage of water would be in the fruits and vegetables, almost was up to 100%. So the woman who is vegetarian will never have problem with fluids, electrolytes. All right, so let's switch gears from fluids, electrolytes to the ABGs. And as I listened to your responses last time, you said that you never been introduced to ABGs until you're on, I think the first or one of the sessions in Adult Health 1, briefly, right? Is that briefly that like in Adult Health 1 about the ABGs? Right? Yes? No?
No.
Adult Health 1 wasn't like introduced the ABGs at all?
No. No, we didn't do that.
Not even in any other courses like a anatomy and physiology or biology or chemistry or?
No.
Well, I covered it in.
Just a little, like the basics.
Okay, So let's start from I would say the scratch or beginning of what is the ABGs. Now, yeah, some of the information I'm not going to read out of the slides, because I'm trying to explain the analysis and the interpretation of the whole process. This is one of the significant. This is very important, because the ABGs, it starts from here, from patho. We will revisit it in adult health too, and then more advanced. It's like introduce, reinforce, right? Reassess. So it's like a 3 levels. Gets difficult as we go up and as we progress to the different levels. So let's start from the beginning. I'm like in the basic kind of concepts of ABGs. So the 3 main components plays a role in maintaining the acid-base balance. So the acid-base balance in our body is being maintained by 3 main components: the pH and the partial pressure of the CO2, carbon dioxide, and the partial pressure of the PaO2. So actually 4 components in addition to the bicarb, but we don't focus much on the oxygen at this point in patho. We'll just focus on the 3 main components: the pH, the PaCO2, and the bicarb. And from chemistry, you know that when the pH is low, then the fluid or the media, and here we talk about the arterial blood gases. So we're looking at the percentage and the level of oxygen and CO2, O2 and CO2, and bicarb in the plasma. So it's a plasma arterial blood gases. So specific here, the media is going to be the plasma, the arterial blood. So the changes in the there are a lot of functions and physiological functions that rely on the balance of the acid-base balance, given all the physiological functions that you covered in other courses, and you can also review the content from the book talking about the almost all the physiological processes. They rely on this acid-base balance. So any change in this acid-base balance is going to change and ruin most of these processes or pathophysiological processes. So let's focus now on the acid-base imbalances and what's the source of these imbalances and how to interpret and do the interpretation and do the analysis and the explanation of the ABGs. So the pH, when it drops less than 7 point, so the blood, so we have certain values for the pH in plasma. We call it normal values. Supposed to be between 7.35, not to exceed 7.45. And anytime you see the plasma pH, so from now on, when I say pH, means the arterial blood gases. It's in the the blood, the plasma, right? Because the arterial blood gases, it's slightly different than the values you get from the venous blood gases. And I'll give you an example of that, like the arterial pH, arterial blood, the pH in arterial blood, supposed to be between 7.35 and 7.35. However, if you draw the blood from the vein, it's going to be lower. That's known, right? That's from AMP, oxygenated versus deoxygenated blood. So the venous will be like around 7.31 up to 7.41. So that doesn't, so make sure that when you draw the specimen, it has to be taken from the artery, not the vein. And we usually take it from either the arterial artery, the radial artery, or from the brachial artery, or sometimes femoral. So these are like 3 main places or sites you get the blood specimen for the ABGs: radial, brachial, or femoral. And you know where each one is located, right? Radial, the wrist; brachial, upper arm, or above the AC joint; and then the femoral, the groin. Now the pH, so from now on, we'll, when we refer to the pH, would be the, and will be the arterial blood gases. So what makes the media more acidic? Which ion will make it acidic? According to the pH, according to this
Hydrogen.
right. Hydrogen ion will make it more acidic. So the more hydrogen ion molecules, the more acidic is the media, the more acidic is the blood, right? So the pH now, more hydrogen ion in the media will drop the pH. So it makes the pH go lower or drop. So less than 7.35, because we know the range is now 7.35 up to 7.45. That's the range for normal pH or within range pH for the plasma. Anytime you test or you review the pH for the plasma and you find it is less than 7.35, then that's out of range, which indicate there is a lot of hydrogen ion retained in the blood, made it more, is it acidic or alkaline in this case? Less than 7.35. pH drops means acidic. So the less the pH is, the acidic is more higher the pH is alkaline. So now we know that the pH lower than 7.35, the presence of the hydrogen ion makes it more acidic, and the lower the number of the pH is acidic. Now, this is the first step as you analyze and do the interpretation for the ABGs, is to identify, is the patient acidic or the plasma acidic or alkaline, alkalotic, acidic or alkalotic or alkaline. So acidic when the plasma pH is less than 7.35, it's over or more than 7.45, it is alkaline, right, or basic. Now, during this process, we have other components. So we have to identify what made this pH to drop or to go up. It has to be either the metabolic or respiratory. So is that the lung, like in the source of that? Is it the patient stopped breathing, or the breaths per minute became like 8 or 9 or 10 breaths per minute, and that's why the patient developed the acid-base imbalances and or the ABG to go off, or the patient ingested 10, 15, or maybe like the whole bottle of aspirin and got aspirin intoxication, right? So it could be that the patient vomiting for like 2 days and develop so we'll go over these examples. I'm going to just there has to be like a reason that the patient developed the acidosis or alkalosis. So the first thing is that you want to identify the pH to see that is it acidosis or alkalosis. Second step is to find out what was the source of and the cause of this acidosis or alkalosis. Was it the lungs, PaCO2, or the bicarb, HCO3? So it has to be that patient, nothing wrong with the GI or the lungs. I mean, the kidneys could be respiratory. Patient, developed ARDS, acute respiratory distress syndrome, or pneumonia, or so then the source of or the cause of the pH to drop or go higher is acidosis or alkalosis, is the PaCO2. In this case, if you find matching pH is less than 7.35, and the CO2, the PaCO2 is off, like let's say it's 50, then it's acidic. So this is acidic and the pH is acidic, and so this is from now on we'll call it the matching component for this patient, because the PaCO2 acidic matches the pH which is acidic. And I'll give you more examples of that for now after this, but it's just let me first explain the buffers, and then the like what regulates the acid bases, because continuously our body goes develop some abnormalities, but it will correct itself. So these compensation and corrections will come from, first of all, comes from the buffers. So the buffers are able to, that's one of the significant components of the acid-base balance system, because they can fix the acidoses and the alkaloses. So so these are examples of the different types of buffers in our body. And even hemoglobin is one example of the buffers. We have lots of examples of buffer system. The buffer system can be, we can use the analogy of the buffer system of the buffers as a sponge. So when the buffer as a sponge, and you drop the sponge in the acidic media, the sponge is supposed to absorb the hydrogen ion H pluses from the media and make it less acidic. That buffer also can correct the alkaloses. If you drop the sponge in the alkalotic or in the basic media, it's supposed to release some of these hydrogen ions that the buffer has into the media, and it will correct the alkaloses. So the buffers can regulate both and can fix both acidic and alkaline media. The other components of the regulation is our lungs, respiratory system. The lungs also can assist in compensating, and in other words, it can also fix the alkalosis acidosis problem by, if let's say that patients developing a metabolic acidosis, then the lungs will decrease the rate of respiration. I'm sorry, increase the rate of respiration. So patients going to hyperventilate, and as we hyperventilate, we will blow off CO2. We get rid of the CO2 because that's the source of acid. Source of the acid is the CO2 in this case. So metabolic acidosis, the lungs here will compensate for the acidosis by increasing the rate of respiration or breathing per minute, so that the patient will blow off more CO2, and that will, once we drop, decrease the CO2 level, that's going to resolve the acidosis. So how is that? How is the CO2 level or the CO2 will fix the acidosis? Because before I go to the renal system, look at this anhydrase equation. This is one of the most important anhydrase equations and from chemistry to explain the acid-base imbalances. H2, so the CO2. So whenever we have an increased CO2 added to the water vapor in the lungs, H2O, that will result in something called H2CO3. And that H2CO3, which is the, what would you call that?
Carbonic acid.
Bicarbonate?
Carbonic acid. It's a carbonic acid. So the carbonic acid, it's an acid, so which means that, the high CO2 will result in acidity. So anytime the patient retains CO2, and how would the patient would retain CO2? Because they are not breathing enough, right? They are hypoventilating. Hypoventilating, they're not breathing at least like 18 or 19, 20 breaths per minute. They are hypoventilating, 8 breaths per minute, then they will retain CO2 in the lungs, plus H2O then will give you more H2CO3. So that's the carbonic acid. So just keep in mind that acidosis in terms of the lung performance, hypoventilation results in CO2 retention and more carbonic acid, so it will result in more acidosis. Then the pH will drop less than 7.35. So far, is this clear for everyone? One of the most confusing parts or pieces of this whole acid base or ABG is this one, because I will get to what is called Rome method, ROME, respiratory opposite, metabolic equal. because when the CO2 goes up, pH drops, right? So CO2 goes up, carbonic acid, acidity, pH will drop, less than 7.35, acidosis. So that's why respiratory opposite, but metabolic equal, and I will explain why metabolic equal. But so far, the respiratory is opposite because of that. High CO2, low pH, right? Is this clear?
Yeah.
Okay, so got that point about the buffers, lungs, and then we have one more system, which is the kidneys. The kidneys, there are too many, I would say, mechanisms. Just want to focus on just one or two mechanisms, how the kidneys will regulate the acid bases, the acid base and the ABGs. The kidneys can excrete or absorb or like retain, excrete in the urine, release in the urine, or reabsorb, retain back to the bloodstream, both the H pluses and the H2O3, the bicarb. So the patient is experiencing a acidosis, let's say acidosis, or first of all, let's just focus on the, if the kidneys is the source of the problem, let's say that this patient has been diagnosed with end-stage renal disease, end-stage renal failure, right? So renal failure, this patient is going to retain potassium, and eventually they become acidotic. So the patient will develop the metabolic acidosis, but the lungs supposed to compensate for the problem. Now, another scenario in which that the problem was patient is hypoventilating, CO2 buildup, pH drops, patient became or developed the respiratory acidosis. And now, what about the kidneys supposed to do something towards fixing or compensating for that respiratory acidosis? Kidneys have too many, can take a lot of actions to compensate. One of the mechanisms is to, what about the H pluses, the hydrogen ions? Are they going to compensate by retaining or letting more of that to be released in the urine? So is it H pluses excretion or H plus retention? What would be the compensation to fix that acidosis, respiratory acidosis?
Excretion.
Supposed to excrete the source of the acidosis, right? Which is the H pluses. More H pluses, hydrogen ions should be secreted or excreted in the urine, and we need more of that bicarb to be reabsorbed. So that's what it can be, at least just for now. Let's just focus on one mechanism, because we have other mechanisms of the kidney can assume or do to fix the acid-base imbalances. Just focus on the H pluses and HCO3 and bicarb. So in this scenario, the kidney is supposed to excrete the excess of hydrogen ion and reabsorb, right? Retain more of the bicarb to fix that respiratory acid. And this is what is called the compensation. Well, the process here, it's a kind of lengthy process. It takes a while, takes sometimes days until these lungs or the kidneys are able to compensate. And we don't usually rely on them completely or solely just on these organs to compensate for the ABG imbalances. We always intervene with like medication and other interventions should be taken or done to fix the acidosis or alkalosis. But just to explain the mechanisms of the compensation and how the lungs or the kidneys will intervene to compensate for the acidosis or alkalosis. So the numbers now for you need to know the numbers by remember the heart, the pH supposed to be 7.35 up to 7.45. The PaCO2 35 up to 45. So you need from now on just to know the three components, the three main elements of the ABGs for now. Other courses, upper level courses, we will go over the other stuff like PaO2 and SaO2. Now the pH, and then the PaCO2, 35 up to 45, and then the bicarb HCO3, 22 to 26. So this is the normal ranges or values for the three elements or main components of the ABGs. So the Rome method here means that the respiratory is opposite. You see how the arrows are pointed up and down here, right? It's not the same direction. But with metabolic, it's the same direction. Up, up, right? Down, down. That's why we say respiratory opposite, metabolic equal. Opposite direction, equal direction. So the first one here on the top, when the pH is high, in this case, you have the pH is over 7.45.
You are hypoventilated.
And that's because of the PaCO2 had dropped. So the drop in the PaCO2, a patient is hyperventilating, right? Patient is respiration is about 32 breaths per minute, hyperventilating, blowing off the CO2. So patient's CO2 dropped to 25. And that resulted in that the pH will eventually drop to 7.31. So that's an example of respiratory acidosis. The patient, so that this is what is called the matching component. So we'll practice, more of these questions and systematically go over the three steps of analysis. The second one, which is respiratory acid, I'm sorry, that's acid, that's the alkalosis. Then next to that, which is the which is the acidosis, that's the patient who's going to hypoventilate and will have a lot, buildup of CO2, right? Hypoventilate, retaining CO2. So CO2 retention will result in an increased PaCO2, and then eventually will make the pH to drop because of the acid. Remember that CO2 plus H2O, right? Because, makes the H2CO3 the bicarbonic acid. So more CO2, acidic. It will make the pH to drop to less than 7.35. So the top one, sorry, I said 7.31. It's supposed to the PaCO2 drops, then that make the pH to go up about 7.47 or 7.48. That's because the CO2 dropped, then the pH will go up. That's alkalosis. The second example here, down here, which is that the PaCO2 had increased to, let's say, like 52, and then the pH will drop to 7.31. So this one will be respiratory acidosis, and this one is respiratory alkalosis. When it's metabolic in nature, or the source of the ABG alteration or imbalances would be the metabolic. So the first one here on the top will be pH up, and then the bicarb goes up. And that's, let's say that in a patient who is ingesting lots of antacids, taking all the time, like constantly taking like Tums, right? So these are a source of metabolic alkalosis. Or patient is vomiting for like 2 days. They're going to release and lose lots of hydrochloric acid. So they will have, develop the alkalosis, and that's metabolic in nature. The second example, so that will be sometimes, so I'm talking about this one, the acidosis. That patient is, I'm sorry, alkalosis, that because of the vomiting, they will lose the, the acid. then they develop the alkaloses. And then another example of, one example of the acidosis, which is the loss of bicarb, like patients who had persistent diarrhea, right? They will lose bicarb, so they will, they will retain more acid, so the pH will drop to less than 7.35. So an example of this, the acidity or the metabolic acidosis will be patient losing, fluid and electrolyte, mostly bicarb from, from diarrhea, like, persistent diarrhea, and then vomiting will be the alkaloses, because they will lose acid and retain more basic. So I will explain later on about the compensation when we analyze the questions and practice the questions. Yeah, just make sure that we understand the mechanism of that. The patient, when they develop acidosis, they automatically will result in hyperkalemia. Patients with hyperkalemia will eventually develop the acidosis. You see that exchange between the K plus and the H plus, potassium, the hydrogen ion. And remember that the hydrogen ion is a source of acidity. So so we have the cell, and the media around the cell is the plasma. So when the patient is hyperkalemic, so we have lots of K pluses in the plasma, that's automatically is going to exchange with the H pluses inside the cell. So it will, the K plus, the potassium will enter the cell, and more H pluses will exit to the plasma and become acidotic. So just remember that acidosis will lead to hyperkalemia. Hyperkalemia will lead to acidosis because of this mechanism of the exchange between K plus and the H plus. That exchange will result in both always go hand in hand, and always, patient with hyperkalemia will end up with acidosis. Patient with acidosis will end up with hyperkalemia. That's very evident in patients with renal failure. You will find that, all the time with patients with end-stage renal disease, they will tend to develop these things. So so let's go over some of the questions. So we'll make it more, to practice and see how much we got, so far about the interpretation of the ABGs. So I'll explain the first one, and then if you have any volunteers, to go to try. So let's start with the first one. When we say the pH is 7.32, is this acidotic or alkalotic?
Acidic.
Acidic. Okay.
Yeah,
So
but
yeah.
it's within normal range.
No, the normal range is 7.35 up to 7.45. So 7.32 is less than 7.35. Acidic. Can you hear me?
Mm-hmm.
Okay. So step 2. So let's just systematically, so we can understand how to analyze the ABGs. Step 1, identify the pH. Is it acidotic or alkalotic? Step 2, acidic. Or this one is acidic, right? Step 2, you will find, you have to find, to find the matching component. In other words, that which one is it, the PaCO2 or the bicarb that is acidic that matches the pH? So the PaO2, PaCO2. Yeah. So the PaCO2, it's over 45, which is acidic. So that's the matching component that matches the acidic pH, right? So supposedly, the patient is hyper or hypoventilating. That's why they develop this.
Hyper.
Hypo.
Hypo.
They retain CO2 because they are hypoventilating. When we don't breathe enough, right? So let's say like, 10 breaths per minute, we are going to retain CO2, right? That's why the CO2 went up to 65, 67. And then the pH drops to 7.32. So far, any question or anyone's confused or, yeah?
I have a question. I know that PaCO2, if it's greater than 45, it's acidic. So for PaO2, what number does it have?
Yeah, we said we have to focus only on just the three elements. Just focus on the three elements for now. Yeah, the PO2 will upper levels will go, and explain the PO2, and this has to do with, with other measurements and other like, criteria, and it's just for now. The three main elements are pH, PaCO2, and bicarb.
Got it.
So so we have identified the source of the problem, which is that's why the pH is 7.32, because the patient is not, or it's just like I'll give you, this is one of the scenarios. Doesn't mean like, it has to be always, the reason patient is hypoventilating. This is just one of the reasons why patients pHs drops less than 7.35. Let's say that the patient is hypoventilating, retained CO2, CO2 went up to 67, right? So that's the matching component. Step 3 is you'll find, for the other organ, or then what is called the non-matching component, in this case would be the renal, the kidneys, to compensate. So the kidney is supposed to compensate for and try to fix the, right? It has to intervene to fix the acidosis. And we said there are many mechanisms the kidney would go through or do to fix the acid. Jeanette, can you please mute? Jeanette Morales. Okay, so the bicarb is 37. So the bicarb, is it within range or out of range? What is the normal values for bicarb?
It's out of range.
Right. The normal ranges is 22 up to 26.
Yes.
22 to 26. So this is out of range. So if the patient experiencing acidosis, Janet Morales, can you please mute?
You can mute her, Professor.
I don't know. Let me see. Oh, okay. Good. All right. So the bicarb is 37, which means that in its units out of range. So is there any compensation? So let's just explain the compensation, the three levels of compensation. The first one, when we say no or zero compensation, we meant by this that the non-matching component, which is in this scenario would be the kidneys, hasn't like intervened yet, did not do anything, hasn't started the compensation yet, which will be evident in two things. The pH is out of range, still hasn't been fixed, and the non-matching component, in this case the bicarb, still it's within range, like it will be between 22 to 26. So that would be no compensation. pH out of range, non-matching component within range. So that's no compensation. Kidneys hasn't done anything to compensate for the acidosis. We said kidney can do a lot of things, right? Retain H pluses, excrete the bicarb. It depends on the scenario. So here it's acidosis. It can excrete more the H pluses and retain bicarb. That would be one of the scenarios to fix the acidosis. So which means that we have, if the bicarb is still 22 to 26, so it's within range, then that's no compensation, 0. Now partial compensation. Partial means the kidneys has began the compensation, but hasn't completed, brought the pH back to normal, because the indication that the compensation is complete when the pH is within range. So the incomplete partial compensation would be that this patient's bicarb started to retain or to build up in the blood, kidneys is retaining, but hasn't reached the full compensation yet. So the bicarb will be elevated because that's acidosis. So the patient's bicarb 37, which means there is partial compensation. So in the partial compensation, you remember two things. The pH is out of range, and the non-matching component is also out of range. So when you see the pH and the non-matching component out of range, that's goes with the partial, or what is called incomplete compensation.
Professor, when you say
Yes.
out of range, like any out of range, for example, if the bicarbonate was like lower than 22?
No, in this scenario, you will never see. That's the unusual kind of scenario. But in this out of range means here that it's has to be elevated.
Yeah.
Unless it's a mixed scenario, that's a different. I don't include mixed scenarios like mixed ABGs, which is that metabolic acidosis and respiratory acidosis, or alkalosis. We don't discuss that mixed cases here. So definitely, because of the acidosis, you will find that the bicarb will be either within range or elevated. So this is one of the scenarios. Let's see. So you will call this respiratory acidosis with partial compensation, or respiratory acidosis with incomplete compensation. So the next, number 2.
Could you repeat that one more time, Professor?
Yeah, it's respiratory acidosis with incomplete. Some call it partial, some call it complete compensation.
Okay.
Number 2. Any volunteers for number 2? Just try. We'll work together. We'll analyze it together. Just try.
Okay. I'll volunteer.
Go ahead, Amy.
All right. So the pH is acidic.
Right. 7.18, less than 7.35 acidic.
I don't know the ranges for the CO2.
The PSCO2 35, 45. So is it out of range or within range?
Within range.
It's within range.
It's within range. Good. So within range. And then we have the bicarb is 15 and supposed to be between 22 to 26.
Set of range.
It's low. It's very low.
Good. Right. So which one is going to match the acidosis? The bicarb or the PSCO2?
Bicarb.
Bicarb.
Bicarb. So the bicarb is less than 22, it's acidic. Higher than 26, alkaline, right?
Mm-hmm.
So the magic component now, it's the bicarb. So you will call this, as you analyze it, and you said this patient is experiencing what type of ABG or like acid-base imbalance.
So basically,
because when it's the CO2, it's respiratory. When it's the bicarb, it's metabolic.
Oh, okay.
Yeah.
It's a metabolic imbalance.
Yeah, what type? You said the pH is acidosis, right? So metabolic acidosis.
Acid. Acidosis. Okay.
Right. So metabolic, because the bicarb 15 metabolic, pH acidosis, so that matches the acidosis. So metabolic acidosis, and now step 3 is to identify the compensation, if there is any. Any compensation?
No compensation.
No. Not that I see.
Because of two things, no compensation. Because the pH is out of range, still hasn't been corrected or brought back to, to normal values. And because of the non-matching component, which is the lungs, PaCO2 within range. So the lungs supposed to, what would we expect from the lungs or anticipate the lungs to do to fix the acidosis from the kidneys, like metabolic acidosis? Now the non-matching, which is the lungs, supposed to do something to fix it.
Hyperventilate.
To compensate. Hyperventilate. Yes, excellent. Hyperventilate to blow off the CO2. The more CO2 being blown off or released from the lungs or by the lungs from the plasma, that's going to bring the pH up, up to normal levels or close to 7.35. That will be partial. If we'll go up to within ranges like pH 7.37, then we can say that complete compensation.
But it's not compensating.
Right.
Exactly. You still have the problem.
Yes.
Okay.
Because the pH is still out of range and the PaCO2 is within range. So the lungs hasn't done anything, hasn't intervened yet to compensate. All right, so I want to take number 3.
You say incomplete and not like hasn't started?
No, this one is no, 0 compensation. Because we have 3 options.
So no compensation, I see.
Right. Yeah, we have complete, partial, no compensation. 3.
Got it.
Okay, number 3. Volunteers for 3? 3.
Professor, by 0 compensation, you mean that the kidneys have not intervened?
For that scenario, for number 2?
Yeah.
Kidneys is the problem.
Okay.
Who would compensate? Who would compensate? The non-matching. The lungs. The lung should compensate. I mean, the kidneys will do something, but that would be later on.
Okay.
Yeah, it will do some, but later on. But initially, the compensation is supposed to come from the lungs.
Okay.
All right, so let's take number 3. And I will leave the last 3 so you will practice more, at home, and then next time, because I'm not going to add more stuff because the immune system is a little complicated. I want to leave it for Friday morning. We'll be fresh-minded and we'll be able to absorb more stuff. So let's just practice more because this requires a lot of practice. The ABGs needs, you have to practice more scenarios. So let's just go over number 3. If anyone wanna, I'm sorry.
Let me try number 3.
Go ahead, try.
pH 7.60. It's alkalosis.
Yes.
When PaCO2 is 30, it's too low. It's low.
What is that? Alkalosis or acidosis?
Acidosis.
That's alkalosis.
Alkalosis.
That's alkalosis.
Alkalosis. Good.
HCO3 is within range.
So yeah, so you identify the pH as alkalosis, PaCO2 alkalosis, and this is the matching component. Alkalosis, right? Alkalosis, matching component. It's not the bicarb, it's the PaCO2 that matches the pH, right?
Okay.
What matches the pH, alkalosis, is the PaCO2, which is alkalotic too. So that's why we call it matching component.
You said PaCO2 is acidic?
Alkalosis.
Alkalosis. Acidic when the PaCO2, it's over 45.
Oh, okay.
So this is respiratory alkalosis, right?
Yes, because of the CO2.
Okay. Step 3, to find out about the compensation.
Focus on the bicarb.
Is there any compensation in this
No compensation. No.
scenario? No compensation because patient's bicarb is within range, right? 23. Yeah, you see, this requires a lot of practice. The ABGs to understand the concepts behind it. So let's just go over some of the conceptually understanding what, why the patient develop, these scenarios out of the 4, ABGs or problems with the ABGs. So respiratory acidosis, carbonic acid excess over 45 in the blood vessels, the plasma. So that's called hypercapnia. When you have high levels of CO2 in the blood, called hypercapnia. And that could happen because patient is hypoventilating, because there's respiratory failure, medications, drugs. You learn about this, about this in the pharmacology class. And, you will think about the opioid analgesics, for example, narcotics. These medications will decrease the rate of respiration, sometimes even to 8 or 10 breaths per minute. It becomes like patient become hypoventilating, or chronic obstructive pulmonary disease, or the paralysis that affects the the muscles of respiration, or the pulmonary embolism. These are examples of why patient would develop the respiratory acidosis. And in this, see here at the bottom of the chart or the figure, is that the lactate, and it said lactate containing solution. So in patients with acidosis, we will treat them with lactate containing solution. This is acidosis because the lactate will be converted to bicarb ion in the liver to fix the acidosis. So to treat acidosis, you give lactate, Ringer's, or any lactate containing solution that contains lactate, because lactate will be converted to bicarb in the liver, and that will be one of the treatments for patients with acidosis, either respiratory or metabolic. Now the alkalosis, which is respiratory alkalosis, that results when the patient's carbonic acid drops, and that would result in hypocapnia. PaCO2 will drop less than 35, and that would result from the hyperventilation, pneumonia, heart failure. Patient is febrile, anemia, especially with severe chronic anemia, liver problem like liver cirrhosis, or patient is who develop what is called the aspirin or salicylate intoxication. The overdose of aspirin would result in respiratory alkalosis, and then the patient develop after that the metabolic acidosis. But initially, from that will be respiratory acidosis, alkalosis. So in alkalosis, we would treat the patient with alkalosis with the chloride-containing solution. If you look at the bottom of the whole chart, you'll find that the solution called any solution that includes chloride, because the chloride and the bicarb, they will be exchanged, like replaced by, let's say, the bicarb replaced by the chloride ion. So you're giving chloride containing solution, because it's going to be replaced by that bicarb. So patient is going to lose the bicarb and excrete it in the urine, and the chloride will be, enter the plasma instead of the bicarb. So patient will lose more of the bicarb. So to treat patient with alkalosis, you will give them chloride containing solution, because the chloride will replace the bicarb ion. And next is metabolic acidosis, and that would result from when the bicarb level is higher than, less than 22, and the bicarb drops less than 22, the blood concentration of bicarb in the plasma less than 22, that will be due to the loss of bicarb, and we said that could be from diarrhea or renal, failure, or from the buildup of ketone bodies in patients with like DKA, diabetes ketoacidosis, and could result also from the renal failure or renal, kidneys fail to excrete the H pluses, the hydrogen ion, overdose, poisoning, and that results in the buildup of the hydrogen ion and then acidosis. But the metabolic alkalosis, that's when the patient's blood bicarb elevates higher than 26, and that could result from the vomiting because we lose from in the vomitus, we lose that stomach acid, so it results in alkalosis, or the ingestion of large amount of Tums or calcium carbonate tablets, or the antacids, severe dehydration. So I think it's that's it for today. It's just to try to practice as much as you can, from these scenarios, and more. And there's also a link called vector something. It's it's in the one of the PowerPoint slides. Give you access to the interactive ABGs. You'll be prompted to question, and then it will we will ask to to give an answer.